As much as I would love to talk with you.
Okay. Okay. Well, good morning, everyone, and welcome to our grand rounds. We got a very interesting topic this morning, and we're going to get three angles on it. First speaker will be Dr. Rachel Lombardo, who's a clinical geneticist who specializes in skeletal dysplasias, metabolic bone disorders, and genetic short stature. Dr. Lombardo earned her medical degree from the University of Texas Medical Branch at Galveston, and then completed a dual residency in pediatrics and medical genetics at Cincinnati Children's in Ohio. She then completed additional coursework in diagnosing skeletal dysplasia at the University of Lausanne in Switzerland. She's certified by the American Board of Pediatrics, the American Board of Medical Genomics, Genetics and Genomics. And her areas of expertise are skeletal dysplasia, fetal care disorders, sexual disorders of sexual development, and congenital diarrheal disorders. She's contributed to professional journals and has been an invited speaker at professional conferences and meetings. She will be followed by Dr. Pam Smith, who's a pediatric endocrinologist and medical director of our Metabolic Bone and Osteogenesis Imperfecta program here at Phoenix Children's. Her clinical and research interests are pediatric rare bone disorders, including OI, hypophosphatasia, and XLH. Dr. Smith completed her pediatric endocrinology fellowship at Washington University in St. Louis. And during fellowship, she received focused training and research experience in rare bone disorders at the Center for Metabolic Bone Disease and Molecular Research at Shriners Children's in St. Louis. She's been the physician lead for regional and national family meetings, highlighting our team at Phoenix Children's. She's a member of the Brittle Bone Disorders Consortium, an NIH-funded research, rare diseases clinical research network consortium, and a multi-center initiative focused on understanding and providing better care for OI. Dr. Smith is a strong advocate for rare disease awareness through representation, clinical care, and research. Then thirdly, we'll have Dr. Megan Wallace, who's associate professor of orthopedic surgery at the University of Arizona, and also practices pediatric orthopedic surgery here at Phoenix Children's. She graduated from Missouri State University with a BS in sports medicine and athletic training at the University of Nebraska, and then went to the University of Nebraska for her medical degree. She completed orthopedic surgery residency at St. Louis University and her pediatric orthopedic surgery fellowship at Al DuPont Hospital for Children in Wilmington, Delaware. She's a surgical director of her OI Imperfecta program at Phoenix Children's and serves as a board member for Janssen's Foundation. She's on the medical advisory committee for the OI Foundation and on the steering committee for the Rare Bone Disease Alliance. She's committed a significant portion of her clinical and academic practice to caring for children with osteogenesis imperfecta. So with that, I'm going to invite up Dr. After I hide these Zoom controls, I'm going to invite up Dr. Lombardo to start us off and augment our knowledge on osteogenesis imperfecta and similar things. Thank you.
Hey, everybody. Good morning. So as Dr. Hartley said, I'm Rachel Lombardo. I'm one of the geneticists here. And I have the great honor and privilege to sort of kick off the Grand Rounds presentation and introduce our new OI metabolic bone multidisciplinary program here at Phoenix Children's, which has been really exciting to be a part of, especially considering the enormous need for the US Southwest region for both short stature and OI. So super exciting. So these are our disclosures. And so I'm here today to talk to you about the genetics of osteogenesis imperfecta. And I'm going to start a little bit different because normally we sort of jump into like all of this gobbledygook as a geneticist and we tell you all of this information. But I'm actually today going to tell you a story. And so this story actually starts when I was 8 years old and my family got cable TV for the first time. So if that tells you anything about how old I am, we were a little bit later to get it simply because I lived in a very rural area of Kentucky. But once we had it, as you can imagine, given my current field of medicine, I was also a geeky kind of kid. And so while my friends were watching Nickelodeon and sort of that first offset of children's programming, I was watching the Discovery Channel back when it was documentaries and information. And there was a gentleman by the name of Dr. Charles Scott. Dr. Charles Scott was a clinical geneticist before we had genetic testing, which means that he did everything based on what he saw in the clinic. And that sort of set off what we do as physicians in the rare disease space on the sort of, we know what the child has, we know what the conditions are, we know the treatment. But Dr. Scott, like many geneticists, wanted to know the answers to why. And so it was his work, along with many of his compatriots and cohorts and people that came underneath him or after him, that really started to sort of tell us, why do we see what we see? Why in OI do we see brittle bones? And so it is the why, that's why I'm here, okay? The goal today is not for you to remember all of this information that I'm about to spit out about the genetics of OI, but simply to get an understanding of why the genetics are so important. Because if you understand the gene and you know the spelling change, and you use that as your brick and mortar to understand what you're seeing in the patient, it gives you a broader understanding, and it is the backbone of what we do in rare disease. So let's start by talking about the story of bone, okay? So for bone, we think of it as something we can see, we can touch, our surgeons can operate on and put back together. But in its most basic form, it is simply collagen 1 fibers with calcium and phosphate. And so we start by making collagen chains. We make 2 alpha 1 and 1 alpha 2, and those are called 1A1. You have 2 copies of that gene, and called 1A2. You have 1 of that, okay? So what ends up happening is you, there's something in the chat. Am I supposed to do anything with that? Okay, yeah, what you do is you manufacture your type 1 collagen, you put down into, you hydroxylate some proline residues, you put it in this nice, beautiful spiral. Those spirals then become fibrils. Those fibrils then become even larger. They form these osteons, and then eventually you form bone tissue. And so when we're talking about osteogenesis imperfecta specifically, even when we're talking about all these other genes that do all these other things, the reality is we're simply talking about what happens to this collagen 1 fiber as it's manufactured and moves outside of the cell and into the extracellular matrix to provide us a skeleton and support. So some basics about the human skeleton. There are 206 bones inside the human body. Most of them undergo a process called endochondral ossification, but there's also sort of this other peripheral process called intramembranous ossification. And a good way to think about these two is one is flat bones and one is everything else. So when we talk about intramembranous ossification, this is going to be our flat bones. This is going to be the bones of the skull. This process contributes to much of the development of the face. It is the scapula, it is the the sternum, the scapula, pieces of the pelvis, okay? This is also the process that we use to close our fontanelles, to close our foramina during embryologic development and then moving forward. And there are specific defects in this pathway that can produce short stature conditions like RUNX2, also known as cleidocranial dysplasia. And then the second process that we make bone is through endochondral ossification. And this is what we're doing in most of our bones, beginning from the second we are conceived. So as we move from that little 3 disc, we start to develop hyaline cartilage that then serves as a precursor that we put bone down onto. This process is what we more commonly think of in short stature conditions like achondroplasia. That is principally a defect in endochondral ossification. The thing about OI is that all bone, regardless of its origin, is all collagen 1. And so both of these processes are impacted by our disorders within the OI and the metabolic bone group. So how does bone form? When we are talking about the most common process, which is endochondral ossification, we're talking about this process that the growth plate is going through to manufacture bone from that growth plate, which is just your chondrocytes, your resting chondrocytes, your hyaline cartilage. We go through this process in a very organized series of steps with a lot of different cellular mediators that are all sort of funneling into it. But the takeaway here is that we start with cartilage, we go through and we produce different collagen chains. And it is the final step as we move out of the hypertrophic zone before we lay down what we call hydroxyapatite, which is just calcium and phosphorus. Where it's that calcification hypertrophic zone that the cells start to secrete type 1 collagen. And so in OI, all of these processes are going on just fine until that last process where we have to stop producing something called collagen 10 and start manufacturing collagen 1. And so this group of disorders that I'm going to talk to you about today principally impact that very last step of making bone. Very complicated process. It has a lot of different places that we can see a change in a gene impacting sort of what the downstream effects are. And for many of these, they all end up with sort of the same bucket. Increased bone fragility, right? Increased risk for fractures, decreased bone density, decreased bone mineralization. But how we get there is very different. And the more we understand about OI and the more genes that we find out, the more we know exactly how absolutely complex this process really is. So OI in the world of rare diseases is actually not rare. It's easy as a geneticist to stand here and say OI is not that rare because I see rare disease all day, every day. And for me, rare is that kid who has something that's 1 in 50 in the world. But OI has been well described for a very long time. We have some very loose genotype-phenotype associations because of the way that the gene change can impact everything. And so what you'll see is a lot of these genes cause a lot of different phenotypes here. So the way to sort of look at, when you look at these types of charts is you're looking at the old, I can't walk over there, sorry. Yes. You can use, you can look at sort of what the clinical description is, but as you can see, especially for these first type 4, which are the most common, they all have the same gene or same 2 genes. And so it does get a little bit complex. And again, is why we need to know what is that gene change? What is that spelling error? And understanding that can sometimes help us sort of figure out, okay, I think this kid's going to end up in this bucket as far as like his phenotype, his likely medical complications. And then you can sort of have an informed discussion with the family, even when we're talking about super rare things or a type of OI that we don't see very often. But like I said, these have been well described. I think this was first published sometime in like 1970 something. We've obviously added to it. Obviously, we've made some gene discoveries in the meantime, but it's still sort of the classification and the framework that which we sort of move forward with management for these conditions. The most common types are going to be called 1A1 and 1A2. They are considered autosomal dominant or de novo, so could have an infected parent who may or may not know, especially when we talk about mild OI. Mom or dad may not know that they are affected. But baby is born, baby has 3 fractures after they started walking, and all of a sudden you're like, oh, we have a family history. The other situation is that we have a baby that's in utero, we've got some rib fractures, we've got some long bone fractures, we've got some bowing. And those are usually spontaneous changes that happen either in the egg or the sperm or shortly after fertilization. We have the prolyl 3 hydroxylase genes, which I had the hardest time sort of remembering until the discovery of the use of markers in the blood for bone turnover. And all of a sudden, all of this started to make sense to me. So in about 5 or 10 years ago, we started to talk about bone turnover markers as a way to sort of determine who needs treatment for osteoporosis. This then extended into the OI world because osteoporosis and OI use a lot of the same medications and a lot of the same strategies for treatment. And so CTRAP, I always want to call it CTRAP, LEPRE1, which is also known as, I think, PHI3, and then PPIB, all form this really kind of like complex that's, involved in your hydroxylation of a proline residue. And so now you can sort of say, okay, this group forms this complex. It's inside the endoplasmic reticulum. This is very different than some of our other collagen stuff, right? And so then you notice, wait, this patient has this gene and they have a form of OI, and we see that, but there's some other stuff going on, like developmental delay, ventriculomegaly, some of these other things. And using the gene, you can work backwards and say, where else is this expressed in the human body? Where else might this cause disruption during development of just the human body in embryogenesis? And so it's a big, very complicated picture, but in the end, it all goes together. And so talking about, hang on, we'll skip that for a second. So talking about bone turnover markers, some of the newer OI types, ADAM TS and BMP1, were discovered. These are autosomal recessive. They're not involved in the manufacturing of collagen, like our previous two types, but instead are involved in cleaving the N-terminus and the C-terminus from the collagen molecule. And now we know we can find those markers in the blood. And then that tells us, what are the osteoblasts doing inside the body? We actually now have discrete chemicals that we can look, and then we can use those to sort of make better judgments about what we're doing with management. So again, starting at the base, working your way forward, how can I improve that patient's management and outcomes? These are less common, but still involve WNT1 and SP7 are sort of involved in that WNT1 canonical signaling. We hear about them more in association with osteoporosis, but there is evidence that they can cause mild OI. And then I had heard that LRP5 could cause it. I hadn't had a case until recently. But that also in just this sort of dynamic play, less about the collagen fibers themselves, but more about the play in between the cells themselves. So again, same phenotype, but you got there from a different way. And sometimes knowing how you got there can really affect what your decisions are. There are also some genes that are involved in the endoplasmic reticulum inside the lumen. These are chaperones. So if you think way back to your biochemistry, these are having, again, nothing to do with the actual generation of type 1 collagen, but actually what we're doing to it after the body makes it. So what does this end up looking like? So this is type 2 OI. It has, sometimes we'll fraction it out 2A, 2B, but overall, this is what you see. So the bones have what type 1 collagen they can lay down, but if you don't have type 1 collagen, you can't lay down calcium and phosphorus. Your bones are very soft, so they look crumpled, they look short, they look bowed. On ultrasound, I'm usually looking for, so like in my prenatal babies, because my other hat is fetal care, I'm looking to see, do I see discontinuity in the long bones in the ribs? And so this is sort of on the most severe end, sort of what you're looking at. More commonly, what we see are types 3, 4, 1. Then you sort of get into this weird gray area of, are you really a 2, but because we gave you bisphosphonates at age 7 days of life, now you're looking more like a 3. So this is always sort of a moving target. But in general, types 2 and 3 are going to be the severe. We used to counsel families and say that type 2 was not compatible with life or life limiting. I think what we're finding now is that the infants that survived to delivery that were able to get on treatment quickly are now sort of what we consider type 3, and type 2 may end up being the babies that unfortunately do not survive to term. I think that as the treatment landscape in OI evolves, we will know more. And then types 1 and 4, these are typically called 1A1 mutations because you make 2 call 1A1 genes, so having more than one that is expressed and produced by the body usually helps sort of rescue, as opposed to when we have called 1A2 changes where you've only got one that you're manufacturing each time. And so these are the kiddos that, like I said, maybe they have fractures after they start walking. Maybe mom or dad didn't even know that they had it, but it is something that we see. And then and Dr. Wallace and Dr. Smith will be able to talk to you much more in detail. But hopefully this gives you a little bit of a story to sort of build what they're talking about and moving forward.
I'm gonna get the floating panel.
So I'm Pam Smith, and so I'm here, I'm really excited to talk about this, it's near engagement. And we have an exciting program right now, so. I'm gonna discuss medical care for children with OI.
You need to click on.
So OI is the most common primary osteoporotic condition in childhood. As Rachel was describing, secondary to type 1 collagen formation and processing errors primarily, but we're learning more about cellular dysfunction as well, other than collagen fibrils. Type 1 collagen is not just found in bone, and this is important to remember, and an aspect that may get forgotten. It's found in joints, muscles, dentition, hearing, and vision. So eyes, ears, it affects cardiovascular system, the pulmonary system, and the GI tract. So it is a multi-system disorder. So multidisciplinary is key. So as far as the musculoskeletal system, type 1 collagen offers bone strength, like a tensile strength, and allowing for load bearing and tolerance. So fractures, when there's an error in type 1 collagen, fractures occur from minor causes. There can be bone deformity, joint hypermobility, muscle weakness, causing motor delay and fatigue, limited mobility, growth deficiency, which Rachel covered a lot of these things well, scoliosis, and then chronic pain, which is sometimes overlooked as well. This is a busy slide because obviously this is the most involved aspect of OI. So as far as ortho, it's about fracture care in the acute situation. So you stabilize, offer surgical correction, and then deformity correction, maybe labral discrepancies, scoliosis, and then orthotics may be needed as well to offer joint stability. Neurosurgery is another aspect that can be missed. It's not as common, but hydrocephalus can occur as well as basilar impagination. So those are very serious complications of OI that can get missed. As far as rehab, PT and OT become very important for especially the more severe the type of OI we have, especially PT. It's important for muscle strength, joint stabilization, preventing contractures, and even getting DME. And of course, OT is important for helping navigate activities of daily living and how to do that independently. And then we have pain, definitely under the musculoskeletal. Analgesics can be done over the counter, topically, prescription. Nerve blocks sometimes are offered. And then, of course, some of our standard pain management strategies, including psychological mind-body methods. So then we get to the medicine aspect, the drugs that we offer. Unfortunately, at this time, and it seems on the horizon, I think this will change, which is great, and we look forward to. But right now in children, we can offer bisphosphonates, and that's about it. These other medications, denosumab, teriparatide, sclerostin antibody, and TGF-beta inhibitor, are all offered in the adult world, and some of it is under research for OI. TGF-beta is also kind of more in the adult world being investigated, so it's not FDA approved yet. So there's trials for that one as well. It's very important to note that bisphosphonates are standard of care. So IV is the standard, and there's different drugs that are offered, which we'll go into. These are typically given by infusion. And they interfere with resorption of bones. They help reduce the resorption, which we'll talk about. Sclerostin antibody is actually something that is actively being researched. We are a clinical site in Ortho, so that's very exciting. And that helps interfere with also bone breakdown and encourages anabolic activity, so bone building. So bisphosphonates, as I mentioned, are anti-resorptive. They're FDA approved for children. And decreased osteoclast activity occurs due to almost like an apoptotic process that causes the osteoclast to become sick, or as you might say. So the medicine does kind of linger in the bone for a while because those cells kind of mature and just kind of become osteocytes and stay in the bone. There's a net positive effect on mineralization by decreasing osteoclast activity. So you get a different balance. So there's oral and IV formulations. IV infusion is favored. We refer to them as Zol or PAM. We also might call them Zamida and PAM. With these drugs, we've seen improvement in vertebral compression fractures, better pain control, better mobility, less GI side effects overall as compared to oral. And then, unfortunately, there is no statistical evidence of reduced fracture rate though, which is really important and something obviously would be a primary aim. So that a lot of the studies are too small. They're not powered very well because OI, it's a smaller group, smaller population. So as far as bisphosphonates and orthopedic surgery or fractures, this has been kind of debated historically, whether the meds should be given or held during a fracture or osteotomy. So osteoclasts play a vital role in bone healing. They help turn over and create callus formation and all of those sorts of things. So are we causing delayed healing by giving bisphosphonates around the time of fracture and orthosurgery? 2 studies have shown bisphosphonates do not adversely affect healing fractures. And following osteotomy, there's not a lot of research on this, and there's different surgical techniques, so it's hard to have a strong study for that. There's no consensus perioperatively. There is no guideline. There's so a lot of centers or providers have to kind of make their own decision based on evidence that's there. So it's often used preoperatively to improve bone quality for spinal fusion and implant attachment. So successful attachment of the rods to the vertebra. Some might discontinue use for 4 months post orthopedic surgery. So they might hold the medication even if the patient is due for the medication. And these meds are usually given anywhere from every 3 months to every 6 months. And then annually in adults. So as far as Phoenix Children's and our approach, it's ideal to infuse post-operatively in the hospital if we can, especially while the patient has a line or an IV. So it's one less, procedure they have to go through, one less visit to the infusion center, and so forth. We don't withhold scheduled infusions where the patient is post-op or there's a fracture. This could contribute to increased fracture rate in the long run because you've missed medication. And there's often reported breakthrough or worsening chronic pain. This is subjective, but a lot of patients really find relief with these medications. And some of them actually can tell you that they know when their infusion is due because they start to feel achy and tired. So maxillofacial and dental tend to be a very big issue, I would say, especially in the adults, but in children as well. About 50% of patients with OI have dental problems. And it's more common, obviously, in the more severe OI, the more severe the dental issues would be. It's worse in the primary teeth than for the adult teeth. And you can have fractures, chipping, wearing down of the teeth. There's severe malocclusion, so the bite is not normal. So you might have an open bite, which leads to a whole lot of other issues, Even chewing can be difficult. Hypodontia, meaning the teeth just aren't coming in very well. And then impacted teeth can occur as well. So there's a lot of dental. You can see in this photo, this is dentinogenesis, and this is the same patient where the top teeth aren't as affected as the bottom, which is always very interesting. So routine care, we want to be doing dental visits basically when the first tooth shows up. Just to see kind of what the health of the tooth is, what we're expecting. Make the, you can do mechanical versus manual brushing. Some would recommend mechanical over manual. Fluoride treatments and fluoride toothpaste are really important in this population. So it's really important that they're seeing the dentist regularly. Sealants are offered, which are kind of a glaze put over the biting surface of the molars to protect them from basically caries, fractures, so forth. Nowadays, they're considering preventative caps or crowns standard of care in some centers where they'll put caps on all of the teeth, like the primary teeth of children, just to help reduce the morbidity around this issue. Bleaching is not recommended. It's not going to help. So it's not going to improve the dentin. So interventions, orthodontist visits are encouraged around age 7 to check for malocclusion, grouting of the teeth. And removable appliances are starting to be favored, obviously, because you're not attaching something to the enamel, which is not of the greatest quality. It's at risk of chipping. So clear aligners and retainers are becoming pretty popular, like in this example. And there's currently research being done with that. And then caps, crowns for teeth that have problems. Extractions often occur, and then dentures can occur even in childhood. And then veneers are becoming quite popular in the older kids. So it seems like the magical number is 50%. So 50% of patients with OI have a hearing deficit. It can be early in childhood, it can be later in adulthood. But it's most common in type 1 OI, so the mildest form. And that's what's been reported. You can have conductive, sensorineural, or mixed hearing loss. And it's secondary, a lot of it is secondary to microfractures of the little ossicle bones in orthocochlea. And there can be middle or inner ear sclerosis as well. So the structures inside the ear scar down, basically. And as far as vision, loose sclera is often associated with OI, but not everyone has the loose sclera. So you do have to be wary of that. I wouldn't rule out OI just because the patient does not have loose sclera. There's higher risk of refractive disorders and glaucoma. So you would want to have a formal audiology eval, probably before school, so make sure they're hearing well before they go to school. And then typically we would repeat that every 2 to 3 years, as long as it's normal. And then if you want to watch for speech delay, there can be recurrent ear infections. And then we would refer to ENT, that's becoming a recurring issue. And then we want to encourage patients to always use ear protection. So going to loud concerts and sitting toward the front without anything like earplugs or anything like that may not be a great idea, just because those ossicles are vibrating really, really hard. Vision, we want to establish with an ophthalmologist, not just kind of standard screening, but a full exam. And we would do that annually. And even the retina is at risk and cornea of some abnormalities. So protective eyewear would also be encouraged if we're at risk of anything happening to the eyes. As far as cardiovascular, there's not as much kind of established, especially in children, but we do know collagen 1 is in the cardiac tissue. So you might see an enlarged atrium, a large diameter of the left ventricle, causing lower ejection fraction. It's very mild as far as we can tell in reported evidence in childhood, but what does that mean for later, in adulthood? There can be some valve regurgitation, usually mild, and then a dilated pulmonary artery or aortic root, which is often associated with collagen disorders. And there can be mild EKG changes, but this is not often seen. So there's no guidelines as far as monitoring children with OI and their cardiac function. But you could consider a baseline echo in the later years, teenage or young adulthood. And then pulmonary tends to be, this is kind of a bigger thing, a bigger issue. There can be extrinsic factors, which are kind of more apparent, right? Short stature leads to smaller lung volumes, scoliosis as well. Rib fractures would lead to compromised breathing, you're not breathing as well, and chest wall deformity. Muscle weakness, limited mobility, these all contribute to decreased function. Intrinsic factors might be lung fiber disorganization. There's been inflammation noted. There's increased alveolar space. So the alveoli kind of merge together and you have less surface area for gas exchange. As far as pulmonary function tests, we do consider that standard of care. It's noted to be the worst in type 3 because they have a lot of the extrinsic factors for sure. And then we watch for increased rates of asthma, pneumonia, and obstructive sleep apnea. As far as management, it's your standard respiratory care, preventative things, smoking, not a good idea. Trying to be fit as much as able, which is very challenging when you're seated or you're fatigued or your mobility is reduced. Working on core strength is helpful. So we might encourage singing, learning a wind instrument, swimming, things that are really using those respiratory muscles. And then we want to get all of the vaccines, encourage all of them, even the pneumonia, which isn't standard, but it's standard in high risk populations. And PFTs are challenging in young children, so we start around age 6 and then repeat every 1 to 3 years, depending on the results. And you could consider a sleep study as well. So there's risk of obstruction. As far as GI functional constipation, it is very common. It's about 50%, again, 50% of OI patients have, dysmotility or reduced motility of the gut. They can even have reflux. There's fractures, short stature, immobility, decreased core strength, excess sweating, and pain meds all contribute to constipation. And then we have mechanical obstruction. So it's bone deformities, pelvic narrowing, protrusio of the acetabuli. And then there can be stressful events in their life. The diet may not be ideal. There could be dehydration. They can't get enough intake, fluid intake. Sometimes intake in general is challenging just due to size. One study noted increased constipation about 40% versus 30% compared to general population, and 51% reported hard, painful defecation. So we all know what's going to happen if a child finds it to be hard or painful. It's just going to perpetuate the problem because they're not going to want to go to the bathroom. And then we have GERD, reflux. And this is a leading cause of mortality in adults with OI. So we want to do our standard things that we do for constipation, preventative measures, encouraging diet, diet modifications, toilet time. We encourage physical activities that cause the legs and body to move around. Maybe discussing with their PT would be a good idea, or encourage the family to discuss with their PT. There's over-the-counter options that we know about. Would encourage reflux precautions, not laying down, for at least 30 minutes to an hour after eating. And then I think what's often overlooked is the need for maybe GI to be involved. So kids can have persistent constipation, even rectal prolapse, and recurring UTIs. So it's important to refer them to GI sooner than later. And they might be able to offer other medications or other things. There have been reports of serious invasive complications resulting in colostomy. So it's been seen it because of megacolon or a C. diff infection. Even there could be mechanical obstruction, so maybe ortho could weigh in if there's pelvic issues there or some obstruction to the outlet. Pelvic osteotomies have been done, but that's very challenging and not very common. And Megan actually wrote an article about this that was good. This is kind of an area that she enjoys talking about and researching. And that's it.
Got it. Okay, I realize I'm talking mostly to non-surgeons, so I'm gonna give you a high-level overview of what we do in the operating room for these patients. So just to review, long bones, mostly when we think about long bones, we're talking about the femur and the tibia and also the humerus. So fractures, these kids fracture a lot. So fracture treatment really varies. It really depends on the age of the patient. It also depends on the type of OI they have. And these patients are often very small. So I kind of joke, but it's true. I mean, some of my patients are 10 kilograms until they're almost 10 years old. And you're like, that's really small. Correct. So our options for surgery are much different. And so it's not just the age of the patient. For really with my OI patients, it's the size and the diameter of the bone. And a little bit of surgeon preference. And then sometimes it's what implants we have available, which in the orthopedic world is really vital. We need to have those implants available. So I've only been here for about 9 months. Before I got here, we didn't have these growing rods here all the time. So if a patient came in, needed them, they would have to order them in. They ship from Canada. Sometimes there's problems at the border. So all these things become an issue. So now we actually have 2 full implant sets for the telescoping rods here, and then also some smaller implants that we didn't have available before, which are really important. So in orthopedics, especially with OI, because we know these patients are going to have multiple surgeries, we like to try and decrease the number of times we need to take them to the operating room. So there are some, we have different implants available. We have some that will grow with the patients and some that won't. So the picture on the left is the telescoping rod that we use in North America. It's called the FD rod or the Fassier-Duval rod. And it's not rocket science. It's just 2 pieces of metal and 1 anchors on either side of the growth plate on the proximal end and the distal end. And then if they stay anchored, then it actually grows with the kids. And you can imagine, you can think there are lots of issues that can happen with these. And then we have some non-telescoping options. So this one here is actually just using the male portion of this FD nail. So the smaller diameter nail. This one is a newer implant that this company has. It's called a slim nail. And you can see it has threads on one end, but not on the other. And then the forearm bones are so small, all we can use are wires. And because they have soft bone, there's a lot of issues with these, mostly with backing out. And we can see all kinds of different fractures depending on the type of OI the patients have. So this would be a type 3 patient. You can see that the bone was quite bowed, and usually, not always, but usually they're going to fracture at the apex of the deformity. This patient has more mild disease, so this patient likely is type 4, and you can see we have that fracture. This is a younger patient with a humerus fracture. And then we can see some of these kind of more what we would consider maybe stress fractures or stress reactions that can then cause a complete fracture. And then just because we put hardware in doesn't mean they're not going to break. And so you can see this is a rod that stopped telescoping. So at one point, this part was anchored down here. It stopped telescoping. And then you can see it's very common that the fracture will occur at the junction of that male and female nail. Yeah. Yeah, so sometimes we use plates and screws, so as well. We don't usually use plates and screws without an intramedullary rod. Is that what you mean? Oh, because it's a small diameter of a rod across the growth plate, we don't see any growth issues of the growth plate itself. If there's something interposed in the growth plate and it's not the threads of the actual implant and it's not bone that's going across there, we don't tend to see issues with the growth plate growing. Good question. And then fracture treatment is really dependent on the size of the patient. So if they're really small or really young, or I don't have an implant that's small enough to put in their bone, then we'll do non-operative management. So standard of care, for example, for a femur fracture in a child without OI is a hip spica cast until about age 4 or 5. And we can do that in OI, but the problem we know that with bone in OI, it doesn't remodel like children without OI. So we can accept some deformity of the long bones in very young children that don't have OI, because as they grow, they'll straighten that bone out and remodel it. But in OI, that does not happen. But if the children are small or they're under a year of age, oftentimes we're using the Pavlik harness in really young children. Sometimes we're just using splints. We can use spica casts. We can use regular casts if it's appropriate. And then I like to use this Surgilast actually as a shoulder immobilizer on these really little kids, just to pin their arm to their side if it's a humerus fracture. This is the classic typical type 1 OI fracture, or these avulsion fractures. Very classic avulsion fracture of the olecranon. This is the typical management that we do to treat those. I've also had patients with tibial tubercle avulsion fractures, which are really common in OI. I had one kid, I actually published a case report on him. He had avulsion fractures of his AIIS off his pelvis, about a year apart. He had type 1 OI and was making poor choices, as most teenage boys who don't have developed frontal cortices do. Plates and screws alone is not an option. So in OI, oftentimes in people without OI, plates and screws are a great option for surgical management for fractures. But because the bone isn't normal, if we just use a plate, there's a stress riser at the ends of the plates, and then they'll get a fracture at the end of the plate, and then you end up having lots more issues. Again, we only use the non-telescoping rods when we have bones that are too small to use the telescoping rods. And then, you know, the telescoping rods have really been shown to decrease the number of surgical interventions these patients need over time, which is really what our goal is. Patients with the more moderate to severe forms of OI, mostly types 3s and 4s, and some of the rare types, can be born with severe bowing of the long bones. Some of these patients will have bowing up to 90 degrees even of their femurs and tibias, so it's quite significant. Especially in the femurs, we know that if the femur is bowed more than 20 or 30 degrees, it's going to break. It's just a matter of when it's going to happen. And so I always tell the families, if I had a crystal ball, I would operate on your child the day before they break their femur, because no family or child wants to experience a displaced femur fracture. They're not fun. They're not fun to have to deal with outside of the hospital setting. And we can do that in a controlled manner in the operating room with adequate pain management, and we can have our anesthesiologists help with blocks and those kinds of things, so that we can try and make that experience as the least traumatic as we can. In terms of bowing, multiple bones can be realigned at the same time, and the centers that do high-level OI care do this very frequently. I always tell the families, in general, in my hands, it takes me about an hour per bone. So if we're doing both femurs and tibias, I usually book the case for about 5 hours because of all the other stuff that happens in the operating room, going to sleep and repositioning and all those things. But it is safe. I have done 5 bones in one day. That's a long day for me and a long day for the kid. But when they break their humerus, the day they're coming in to see you for surgery, you just fix it. There are some, in orthopedic literature, especially in rare disease, it's really hard to get good high-level data. So all of our data is retrospective. This is one of the original studies that came out from you'd see the Dr. Francois Fossier of the Fossier Duval rod. So he's the one who came up with the rod. This was some of the first 60 patients that he had operated on. You can see his mean age of first femoral rotting was at 3+11 and had quite a big range of 1+2 to 11+8. But they did show that the functional outcomes of these kids at a year out from surgery was significantly better. They found benefits in ambulation, gross motor function, self-care, and mobility. And you can imagine if you're operating on a 1-year-old who's not walking yet, like how do you know that when they start walking, it was sooner than when they were going to start walking? I don't know, right? So you have to look at lots of different things, but they felt that especially taking care of kids before rods were around, these types of rods, that they felt like the advances that they had in mobility were beyond what was expected for their physiology. And then here's another study that looked at lower extremity rotting. You can see this was just early follow-up, but it's not uncommon to have to reoperate on these patients. So you can see they had a 13% reoperation rate for rod migration, which this happens. The bone's soft, even though there's threads on these rods and we're screwing them in, they can back out. You can see a 40% complication rate. And some of these complications, I mean, we're reporting these complications as complications, but it doesn't mean the patients always need repeat surgery. And so there's a wide range of what would be considered a complication. This study came out in 2018. That's actually looked at the telescoping rods versus static implants. So rods that don't telescope. And you can see they found the hazard ratio was 13.2 times higher in the non-telescoping rods. Yeah.
Showed the smaller kids that have the non-telescopic rods.
Yep.
Looked like the length of the rod was longer than the entire feet. Is that just hoping that the feet are just going to grow into that rod? Like it actually went through the end of the feet.
Yeah, so we want to protect the entire long bone. The rods, when we're cutting them and things, sometimes they'll actually look like they're sticking out of the bone, but they're actually in cartilage. So in very young children, parts of the bones haven't ossified yet. And so when you look at the implant, it'll look like it's in nothing. It's in something. It's in cartilage that's eventually going to turn to bone. But yeah, we try and maximize the length of it to decrease that the next time we're going to need to reoperate on them.
Are they from America?
The FD rods were first made in Canada. Yeah. This study came out from my last institution. This was the first 58 patients that my senior mentor had operated on. He published this in 2018, but these kids, there was quite a long follow-up for these kids. And you can see about 30% of the patients, he did both femurs and tibias at the same time. So these were quite young. And you can see that 53% of patients required a revision at a mean time of 52 months. So it's quite broad. I did a follow-up study. It's not published yet, but we showed that that usually we can get about 3 to 4 years out of the first set of rods if we do them under the age of 4. And then the next, oftentimes then if there aren't any complications, then they'll need to have them revised due to growth after about 3 or 4 years. And then again, if we don't have a complication with that, then they'll need to be revised usually at least one more time, usually in that junior high-ish time frame. But this is what a typical patient would look like. So you can see that significant bowing, and then you can see the rods after surgery. And you can see just because there was some bowing in the tibias, I talked to this family, this kid had never had a tibia fracture. And so we elected to not do the tibias, which is very reasonable because with the femurs, we know if they're bowed 20 to 30 degrees, they're going to break. With the tibias, we don't really have, I've got kids that are walking on tibias that are bowed 30 or 40 degrees and I've never had a tibia fracture. So every family has a different level of risk. And so we talk about that and proceed from there. One thing that can be common in OI is something called coxa vara. So if you look at the picture down here at the bottom, the normal neck shaft angle, so the shaft of the femur and the neck of the femur is about 130 degrees. And in these kids, sometimes the neck shaft angle will decrease. I've tried to look and see because it seems like when you look at these, it's always the kids that we have done rotting surgery on, but that's not the case. I've looked at the cases of coxa vara that we've done, and it happens even in children that don't have rods placed. It also happens in kids who have never ambulated a day in their life. So the bone is just really soft, and as that happens, you'll start to see these little changes in the neck of the femur, and over time that neck shaft angle will decrease. And so there's the surgery we do to correct that is much more extensive than just the regular osteotomy surgery to correct bowing. We put these wires into the neck of the femur to support that area. And then this is actually cerclaged around the shaft with some suture to hold those wires in place. And this does very well to help correct that coxa-vara. The waddling gait, if you end up coming and seeing a lot of our OI kids, a lot of them do this walk, and that's because their hip abductors are really weak. And sometimes that happens, the hip abductors are even weaker when you have coxa-vara, so these kids really waddle a lot. But sometimes even without coxa-vara, these kids will waddle just because they have that core, hip and core weakness. Again, Dr. Fossier published his cases. Coxa-vara is much less common, so you can see he only had 18 cases, but had very few complications and was able to restore that neck shaft angle adequately. And then, and these are some other examples from that paper with some different, these are some older style rods that we don't use anymore. The other thing that we can do, we do this very commonly in kids without OI, is guided growth. So the growth plate is super powerful, and we can actually use that to our advantage. So I published on this guided growth with some of my colleagues in Delaware a couple of years ago, but it works really great in OI, even though the growth plates grow a little slower. If we can put these guided growth plates where we're tethering the growth plate on one side, we let the other side grow, the kids can actually, as they finish growing, can correct their deformity, and it works really nicely. Especially for, we can use it for both bowing of the legs, and also knock knees. As well. And then upper extremity deformities can be quite common, and they can be pretty debilitating, especially you can imagine if a child is a wheelchair ambulator, they need their arms, and if they keep breaking their arms, they're not able to be independent. And so this can be quite debilitating for them. But you can see quite a bit of deformity in both the humerus and the forearm. And again, when we look at research in surgical care of OI, if you look at papers from lower and upper extremity, there's only about 10% of the papers that are out there about the upper extremity. So historically, we've really focused as orthopedic surgeons on the lower limbs, which you can understand a femur fracture, right? Like it hurts a lot, like we want to look at that, but the upper limbs can be quite debilitating as well. And some of the reason why people don't want to offer upper extremity surgery is it tends to be a little bit more technically difficult than the lower extremities. And because the bones of the forearm are so small, our surgical options in terms of hardware are much less. And there has been a historical belief that upper limb deformities are well tolerated by patients, but if you really talk to them, they're not tolerated that well. And so we can do surgical correction. It can be quite dramatic, some of these deformities. And like everything, I think I'm running out of time. There can be hardware complications. But these, again, telescoping rod and non-telescoping rod options. And this is a patient, this makes me really want to operate on these kids early. This is a patient, a teenage patient who's a wheelchair ambulator, had this fracture, was treated in a fracture brace, which in a normal kid without OI who had a fracture that would be very appropriate. But as he healed, you can see he went from this at about 6 weeks to this at about 3 months, and he was miserable. He couldn't use his arm. But the surgeons where he lived kept telling him he didn't need surgery. And so these families will reach out to me, and you can see this is the treatment that I did, and they were very happy because he was able to use his arm again, like he did before. Anatomy wise, the upper extremity, the radial nerve is always right where the deformity is in the humerus, and the radial nerve does not like being messed with. So I lay crepe with these families that they could get a radial nerve palsy. Knock on something, every kid that I've had a radial nerve palsy post-op has resolved within a matter of weeks to months. But I always warn them about that. And the non-union in the distal humerus is really a big problem that a lot of us in the surgical OI world are looking at, but I think skip some of this stuff. And then just surgical management, so scoliosis, full disclosure, I'm not a spine surgeon, but our spine guys here are great. But scoliosis is really common in OI, and so it's something that we're watching with x-rays every year of the back to monitor that and also to look for compression fractures. Because of the soft bone, there can be a lot of complications with spine surgery as well, but it does oftentimes need to be treated. We're happy to entertain questions, but I also know we're over time, so. Thank you all very much. Yeah. Yep.
It doesn't seem like, OI patients would tolerate that.
Yeah.
It seemed like, I think that very early. Modification, keep it in the FO, body.
Yeah.
Like health question.
So the comment is about metacasting. So if the patients are really young and I have infantile scoliosis, not OI, oftentimes they will do casting. The problem with the metacasts work by pushing on the ribs. And the problem with OI is they can have a lot chest wall deformity. And if they have issues in childhood, most of the kids with OI, if they have a mortality in childhood, it's because of pulmonary issues usually. So we don't tend to use casting or bracing on scoliosis and OI because we can actually cause more chest wall deformity because of that. In the patients with more mild OI, if they're in that adolescent range, we'll try bracing sometimes, like in more of our type 1 or mild type 4 patients. But if we're doing some sort of brace in a type 3 patient, it's usually just to help support them. It's not necessarily to try and help prevent progression of scoliosis.
Yeah, the biggest issue that we run in with like moldables, like casts, AFOs, that kind of stuff, is that the bones are a dynamic process in the state, and they're soft and they're moldable. And so things have been tried, like helmets to help reduce like skull modeling and stuff, and they've all failed because as we try to correct one issue, we cause another.
Yeah.
The race part.
Exactly.
Yeah, and the more you immobilize kids with any kid really, but especially a kid with OI, if you immobilize someone, they get disuse osteopenia and they already have osteopenia because of their OI. So then you can get into this vicious cycle where they keep breaking if you keep immobilizing them. And so trying to immobilize them the least amount of time possible is really what our goal is for that.
Okay, we'll end with one yes or no question. One thing I took away from this is that you can't have OI without blue sclera, which is one of the things we're always taught to ask when we're doing a child abuse evaluation. So have any of the three of you who see probably most of the OI kids around here, have you ever seen a kid that had OI get misdiagnosed as child abuse?
Oh, yeah, we always see that. Yeah.
Okay.
But I also would say every person that has blue sclera doesn't have OI.
Okay. So what would be the take home point as far as if we have a kid with fractures and we're trying to figure out, do we need to call DCS or do we need to call a geneticist and orthopedic?
Both.
Call them both. Okay. And if you guys say he doesn't have doesn't have OI, then he doesn't have OI.
And we do a very complete workup in these cases to make sure that what we are saying, and I think also it is important to realize, guys, you can have OI and
Still have abuse.
be abused.
Yeah.
So just because you have OI and fractures, that does not mean that your fractures are just because you have OI.
Yep.
Okay, well, thank you all. If any other questions, feel free to come on up, but I need to let you guys get to your. Thank you.
Thanks.